Good morning or evening, everyone. I am Valériane Leroy, clinical epidemiologist working at INSERM at Toulouse 3 University in France and on child and adolescent global health in Africa. Today, I am delighted to chair this new session specifically built within the International Pediatric HIV Workshop Program to cover the COVID-19 pandemic in children. This global pandemic emerging since 2020 has changed our daily life everywhere and leading us to conduct virtually this session today. This pandemic represents complex health, social, and economic challenges worldwide and is also impacting child and adolescent lives everywhere in the world and raising many challenging questions to HIV research too. First, on the specific direct impact of SARS-CoV-2 infection in child and adolescent living with HIV in terms of epidemiology, clinical conditions, diagnosis, interventions, treatment, and vaccines that we hope for soon. But this pandemic also raised the question of assessing its indirect public health impact on delivering sustainable HIV pediatric services and also the mental health issues in these vulnerable populations. It is very stimulating to see how the whole HIV research community is reacting promptly to this new global health challenge, with many researches ongoing. Today, to illustrate this in this session, 5 oral abstracts were selected, addressing some of the many issues raised. So today, the 5 abstract presenters will be presented first. Then we will have a question and answer joint session at the end of the whole presentation. So I am pleased to introduce the first abstract presenters today, Ariana Traub, who will present a multi-country analysis of the impact of COVID-19 on HIV services for children and adolescents living with HIV for USAID. Ariana, you have the floor now.
Hello, my name is Ariana Traub. Today, I will be presenting our analysis on the impact of COVID-19 on HIV services for children and adolescents living with HIV on behalf of our team, Anouk Amzel, Megan Gleason, Nimasha Fernando, Mina Srivastava, and Alex Vrazo from the USAID Office of HIV/AIDS Prevention, Care, and Treatment Division. Thank you to the International Workshop on HIV Pediatrics and the coordinators for the opportunity to present our findings today. This presentation was made possible by the support of the American people through USAID under PEPFAR. The views in this presentation are those of the author and do not necessarily represent the views of USAID, PEPFAR, or the United States government. The authors have nothing to disclose. The COVID-19 pandemic has created a unique challenge for health systems across the globe as they adapt to new social distancing policies. Since March 2020, USAID PEPFAR-supported countries have adapted programs in an effort to continue supporting children living with HIV, or CLHIV, through testing, treatment, and case management. This study assessed the impact of these COVID-19 restrictions on HIV services for CLHIV. USAID PEPFAR data was analyzed from 13 countries, comparing the relative changes from fiscal year 20 quarter 1 to fiscal year 20 quarter 3, or October 2019 to June 2020. This study looked at the overall volume of testing, the number of HIV-positive children identified, linkage to antiretroviral therapy, or ART, ART coverage, as well as viral load coverage and viral load suppression rates. For this study, children were defined as less than 15 years old. 13 countries where PEPFAR USAID is supporting CLHIV services were selected for this analysis. These include Burundi, DRC, Eswatini, Haiti, Kenya, Lesotho, Malawi, Mozambique, Nigeria, Tanzania, Uganda, Zambia, and Zimbabwe. Here, we are looking at the overall testing volume, number of positives, and number new on ART. On the x-axis is the 3 quarters in fiscal year 20, from October 2019 to June 2020, while the y-axis is the overall number of children. The total number of children tested for HIV dropped by 40%, or 119,416 tests, from fiscal year 20 quarter 2 to fiscal year 20 quarter 3. Additionally, the total number of CLHIV who were identified as positive also decreased by 22.3%, or 1,608 children, from quarters 2 to quarter 3. Despite the decrease in numbers of CLHIV who were identified as positive, the percentage of positive tests, or the positivity, increased from 2.4% to 2.7% from quarters 2 to quarter 3. Additionally, the percentage of children linked to ART, or the proxy linkage, which is defined as the number of new CLHIV divided by the total number of CLHIV who were tested positive in that quarter, increased from 94% in fiscal year 20 quarter 1 to 105 and 104% respectively in quarters 2 and quarter 3. When looking at the second and third 95s of the treatment cascade, we notice that the overall number of CLHIV on ART increased by 7.2%, or 12,408 children from quarters 1 to quarter 3, but with noticeably less growth from quarters 2 to quarter 3. The viral load coverage, or the percent of CLHIV on ART who received a virologic test, decreased across the quarters, from 80.9% to 76% from Q1 to quarter 3. Of those who received a virologic test, the percentage of those who were virologically suppressed, or the viral load suppression rate, increased from 70.6% to 74.5% from quarters 1 to quarter 3. To summarize, our results show that across 13 PEPFAR-supported countries, HIV testing volume, the number of CLHIV who were newly initiated on ART, as well as the viral load coverage rate all decreased from fiscal years 20 quarter 1 to fiscal year 20 quarter 3, October 2019 to June 2020. However, the HIV positivity rate, the viral load suppression rate, as well as proxy linkage all increased across these 3 quarters. Retention of CLHIV on ART was maintained across the 3 quarters. Importantly, the decrease in overall testing, but increase in positivity, may be a result of more targeted testing of those children presenting to the clinic with symptoms and reduce non-targeted facility-based outpatient department testing, resulting in a higher positivity rate. However, additional analysis is needed to fully understand this result. Based on these data and current PEPFAR recommendations, we encourage countries to continue to prioritize safe and effective services for CLHIV during the COVID-19 pandemic, including scaling up index testing, targeted testing at sick entry points, improving access to caregiver-assisted HIV self-testing for children who are over the age of 2 years old, scaling up multi-month dispensing of ART, ensuring children are receiving optimal ART regimen, as well as providing virtual case management when available. Thank you very much for your time today.
Thank you very much for your presentation, Ariana. Let me introduce the second abstract presenter. Cheryl Pikora will present the challenges of remdesivir pediatric development for SARS-CoV-2 infection in a pandemic, and she's doing this presentation for Gilead. You have the floor, Cheryl.
I'd like to thank the meeting organizers for inviting Gilead to present on remdesivir challenges of pediatric development for SARS-CoV-2 infection during a pandemic. My disclosure is that I am an employee of Gilead Sciences. The first challenge we faced was, at the time the pediatric development plan for remdesivir was needed, we knew little about disease severity or incidence in children. US, EU, and Chinese publications in the spring provided insight and demonstrated a fairly low incidence of COVID in children. Few children are noted to have severe disease, while in the middle of designing the pediatric study, cases of multi-system inflammatory disorder were being reported. So it was clear that at that point, some children had classic respiratory symptoms, whereas others did not. The point of this slide is to show that pediatric COVID-19 cases have been on the rise from a rate of 3% in April, when we were designing the study, to now a little over 10% in October. And although most children don't require hospitalization, as many as 7.5% with a proven case now are ill enough to be hospitalized. At this time, remdesivir was being studied as a treatment for COVID-19 in adults. Remdesivir is a broad-spectrum antiviral drug with activity against coronaviruses with a low EC50. Additionally, data from SARS-CoV-2 inoculated rhesus macaques showed a reduction in clinical scores in monkeys treated with remdesivir versus placebo, and a reduction in pathological changes in the lung. The next challenge was choosing an appropriate study design in terms of using a single-arm pharmacokinetic or PK and safety study versus a controlled study. What helped us decide were preliminary results, now made final, of the Act 1 study. This was a double-blind randomized placebo-controlled trial of remdesivir in adults hospitalized with evidence of lower respiratory tract involvement, given remdesivir or placebo for up to 10 days. The primary outcome was time to recovery. The results of the study showed a statistically significant shortened median recovery time for remdesivir relative to placebo. So this proven efficacy in adults allowed us to move forward with a simple one-arm PK and safety study design for children. This choice of study design is one supported by the FDA's pediatric rule, in which pediatric extrapolation of efficacy from adults can be done using PK bridging if the course of the disease and the product's effects were similar in adults and pediatric patients. The third challenge was the choice of remdesivir dose to use in the pediatric study. PBPK modeling is a physiologically based model that considers ontogeny and age-related changes in organ development and function, and was used to generate a dosing nomogram for pediatric administration of remdesivir. The fourth challenge is how we could obtain sufficient PK data from children with stringent precautions for COVID for hospital staff and in children who are potentially critically ill, requiring intensive interventions. We did not feel comfortable with an intensive PK sampling plan in this setting, but went with sufficient sparse PK sampling to be able to measure the metabolite shown above to use in a robust population PK model of remdesivir in children that would ultimately provide the study's primary PK endpoint. A fifth challenge is remdesivir is not orally bioavailable, so needs to be administered IV and has different pH requirements for optimal solubility versus chemical stability. The formulation needed cyclodextrin to increase solubility, while the study of remdesivir in children required minimizing cyclodextrin. We therefore chose to go with the lyophilized powder for solution to minimize the cyclodextrin exposures. Another challenge was that we needed to move quickly during a pandemic to put into place pediatric plans for remdesivir in order to start the implementation of these plans. Gilead had several meetings with regulators in the US and EU, as well as external experts, to help with the pediatric development plan, as well as the study design. This approach was highly collaborative and led to unprecedented timing in PIP and PSP approvals and study startup. Once the basis of ongoing accumulation of pediatric clinical data from published observations, as well as the adult data, were collected and input from regulators was obtained, the study, referred to as CARAVAN, was designed. Key inclusion criteria are lab-proven SARS-CoV-2 infection and hospitalization and absence of renal or hepatic failure. All children over 2.5 kilograms and at least 14 days of age are enrolled in parallel and divided into cohorts above in the interest of spanning an adequate range of weight with an appropriate sample size. Participants are treated up to 10 days with daily remdesivir, and clinical assessments in multiple safety labs, as well as PK assessments, are performed as indicated on the slide, with a final visit at day 30. A significant challenge to this design was the size of some of these participants and the blood volume limits, for which we consulted a pediatric laboratory specialist. In conclusion, despite these challenges, we initiated the study successfully and enrolled our first participants in July. As of October 19, there were 20 participants enrolled across cohorts 1 through 4. We've had enrollment challenges as children seem to be managed more conservatively now, having learned from earlier cases, and fewer given a remdesivir course. The rate of symptomatic and hospitalized children has been fairly low, which necessitated opening additional sites. So we're over 25 sites at this point in the US and EU. We have an external data monitoring committee, or IDMC, meeting coming up soon to review the safety outcomes, which is triggered once 50% of subjects have been enrolled and reached day 10. And we reassess on a daily basis whether new sites might enhance enrollment based on epidemiologic data, and we anticipate study completion at the beginning of next year. Lastly, we like to express our solidarity with those who have been ill or are ill with COVID-19, their families, and the healthcare workers on the front lines of this pandemic. And we extend our thanks and appreciation to the Caravan study patients, their partners and families, the frontline healthcare workers caring for them, the study staff, and study investigators. Thank you very much.
Thank you for your presentation, Cheryl. Nimasha Fernando has the floor to present a multi-country analysis of the impact of COVID-19 on impact of multi-month dispensing for children living with HIV on antiretroviral therapy. Doing this for USAID. Thank you. You have the floor now.
Hello, my name is Nimasha Fernando. Today I will be presenting our multi-country analysis of the impact of COVID-19 on uptake of multi-month dispensing for children living with HIV on ART. On behalf of our team listed here from the USAID Office of HIV/AIDS Prevention Care and Treatment Division. Thank you to the International Workshop on HIV Pediatrics and the conference coordinators for the opportunity to present. This presentation was made possible by the support of the American people through USAID under PEPFAR. The views in this presentation are those of the authors and do not necessarily represent the views of USAID, PEPFAR, or the US government. We have nothing to disclose. Children living with HIV, or CLHIV, who are stable in ART are eligible to receive multi-month dispensing, abbreviated as MMD. MMD is defined as receiving a 3-month or greater supply of ART. Advantages of MMD include promoting continuity of ART, as well as decongestion of health facilities due to less frequent ART pickups. These advantages are key priorities, especially during COVID, when efforts seek to reduce potential exposure to SARS-CoV-2 at health facilities. Although MMD has benefits, uptake is varied by country during COVID-19. This analysis reviews USAID PEPFAR MMD data to assess the uptake of MMD and proportion of CLHIV 0 to 14 years old on ART receiving MMD. Data is from fiscal year 2020 quarter 1 to quarter 3, so October 1st, 2019 to June 30th, 2020. ART categories were defined as less than 3-month supply, 3 to 5-month MMD, or 6 or more month MMD. Treatment volume was defined as the total number of 0 to 14-year-old CLHIV on ART. 12 countries listed here where PEPFAR USAID is supporting CLHIV and MMD were selected for this analysis. Moving to the results, in the following slides you will see the 12 countries represented along the x-axis and the percentage of children 0 to 14-year-old on treatment along the y-axis. Red columns represent fiscal year 2020 quarter 1 data. Yellow columns represent Q2 data, and green columns represent Q3 data. Our results first showed that from FY20 Q1 to FY20 Q3, the mean percentage of CL-HIV on treatment receiving less than a 3-month supply of ART decreased from 65.2% in FY20 Q1 to 39.2% in FY20 Q3. In every country, the percent of CL-HIV receiving less than 3-month supply of ART decreased from FY20 Q1 to FY20 Q3. This decrease may reflect more CL-HIV transitioning off of the less than 3-month supply and onto a longer MMD supply. When looking at the percentage of children receiving 3 to 5-month MMD, we see that the percent increased in all countries during COVID-19. In FY20 Q1, the mean percentage of CL-HIV on treatment receiving 3 to 5-month MMD was 33.6%, but grew to 54% in FY20 Q3, an increase of 1.6 times as 84,725 CL-HIV were receiving 3 to 5-month MMD by the end of FY20 Q3. However, the range of percentage of CL-HIV receiving 3 to 5-month MMD in FY20 Q3 was between 28.2% in Uganda to up to 90.4% in Eswatini, reflecting differences in uptake by country. The number of CL-HIV receiving greater than or equal to 6-month MMD more than doubled from FY20 Q1 to FY20 Q3, jumping from less than 4,000 CL-HIV in FY20 Q1 to 10,869 in FY20 Q3. However, the percentages of CL-HIV on treatment show that the percent of CL-HIV receiving greater than or equal to 6-month MMD remained low, and only reached 6.7% by the end of FY20 Q3. The range of percent of CL-HIV receiving greater than or equal to 6-month MMD did vary from 0% in Mozambique to 17.3% in Nigeria, again showing varying MMD by country and possibly also reflecting varying national policies on 6-month or greater dispensing. To summarize, our results show that for CL-HIV 0 to 14 years old in the 12 included PEPFAR USAID supported countries, dispensing of less than 3-month supplies of ART decreased during COVID. 3 to 5-month MMD increased moderately, and 6 or greater month MMD increased, but overall numbers remained low. In conclusion, MMD uptake increased during COVID for 0 to 14-year-olds from FY20 Q1 to FY20 Q3. Given the advantages MMD offers, such as helping families synchronize ART pickup, decongesting health facilities, and helping free up resources that can be dedicated to newly diagnosed and virally unsuppressed people living with HIV, MMD should be standard of care for stable CL-HIV. Even as COVID-19 restrictions lessen, we recommend that countries continue to prioritize MMD for CL-HIV and continue efforts to ensure stable CL-HIV less than 20 kilograms can access a 3-month supply of ART, and CL-HIV greater than or equal to 20 kilograms can access at least a 3-month supply of ART, with the goal of access to 6-month MMD. Thank you.
Thank you very much, Nimasha. So now, Alexandra Vrazo is going to present a multi-country analysis of the impact of COVID-19 on HIV services for pregnant and breastfeeding women and their infants, doing this for USAID.
My name is Alexandra Vrazo, and today I will be presenting Abstract 22, a multi-country analysis of the impact of COVID-19 on HIV services for pregnant and breastfeeding women and their infants. On behalf of our team at the Office of HIV/AIDS at USAID, I'd like to thank the International Workshop on HIV Pediatrics, as well as the conference coordinators for the opportunity to present. We have nothing to disclose. Ensuring access to HIV services is crucial for pregnant and breastfeeding women and their infants during the COVID-19 pandemic. These essential HIV services comprise PMTCT programs, including maternal HIV counseling and testing at both antenatal and postpartum settings, ART for the mother, and regular monitoring of her viral load during pregnancy and breastfeeding. For the infant, these PMTCT services include prophylactic ARVs, as well as access to timely infant virological testing. Since March 2020, countries supported by PEPFAR through USAID have adapted interventions to ensure continued access to HIV clinical services for pregnant and breastfeeding women and their infants during the COVID-19 pandemic. We wanted to understand, what has the impact of COVID-19 been on the USAID PEPFAR PMTCT program, and also what can we learn about service delivery to inform future directions? So the objective of this work was to quantify differences between time periods to understand any impact of COVID-19 on PMTCT programs. The data source was USAID PEPFAR MUR data from 11 countries, and the measures were pregnant women tested for HIV and those receiving ART, as well as HIV-exposed infants tested by 2 and 12 months of age. The analyses performed included a comparison of reporting periods before and during the COVID-19 pandemic, which we define as Q2 and Q3 of FY20, respectively. Knowing that we see increases and decreases in the number of sites supported by USAID, and therefore the number of beneficiaries reached from one fiscal year to the next, we wanted to also compare this data with the same time period in the previous fiscal year 19. We also analyzed trends over time for PMTCT data. The 11 countries selected for this multi-country analysis had significant USAID PMTCT programs, and so the following data is shown in aggregate from these 11 countries. Looking at HIV testing in pregnancy, we found that the overall number of women counseled and tested for HIV at their first ANC visit decreased by 8% between Q2 and Q3, as shown by the blue line. This was a slightly larger decrease when compared to the same time period in FY19 of 3%. On the right, we reviewed the trend in HIV testing coverage at ANC1 and found no significant decrease between Q2 and Q3 of FY20. Looking at the new HIV diagnoses made among pregnant women, we found a 9% decrease in the absolute number of pregnant women living with HIV who were identified in Q3 compared with the previous quarter, as shown in the blue line. This was a slightly larger decrease compared with the previous fiscal year of 6%. On the right, we reviewed the trend in positivity rate at ANC1 and found no significant decrease between Q2 and Q3 of FY20. Taken together with the data on the previous slide, this suggests that while the COVID-19 pandemic may have decreased overall the number of women entering ANC, it did not necessarily impact the provision of HIV testing and counseling services or case finding through the ANC platform. Regarding ART for pregnant women, we observed an 8% decrease in the number of pregnant women receiving ART during COVID-19 in Q3. However, this decrease was also similar compared to the previous fiscal year comparison of 8% versus 7%. On the right, trend data for ART coverage for pregnant women indicates that pregnant women received ART at the same rate in Q3 compared to Q2. As a quick note, ART coverage over 100% may indicate women who have been diagnosed with HIV outside of USAID-supported sites, but later entered USAID-supported sites to receive ART. Therefore, these women would have been reported in the numerator, but not in the denominator used in the coverage calculation. Looking at whether COVID-19 impacted virological testing for HIV-exposed infants at USAID sites, we found that the number of infants tested by 2 and 12 months of age decreased during Q3 compared to the prior fiscal year, where we saw an increase during this time period. Increasing the testing of HIV-exposed infants by 2 months of age is a priority for PEPFAR PMTCT programs. So on the right-hand side, we assessed whether COVID-19 had impacted testing coverage. However, we found this to not be the case. There was no major difference between Q3 in terms of the coverage of infant testing by 2 months of age compared with Q2. So in summary, women and infants have continued to seek PMTCT services during the start of the COVID-19 pandemic, despite some modest decreases across the cascade. These modest decreases may suggest potential missed opportunities for HIV diagnosis for mothers and infants, and we are following up closely with the country teams to assess whether catch-up campaigns are needed. So despite these small decreases in the absolute number of mothers and infants accessing services, the maintenance of ANC testing rates, maternal case finding, ART coverage, and infant virological testing coverage suggests that PMTCT services were still able to be provided at USAID-supported sites across the 11 countries studied in the context of COVID-19. So our recommendations are that during COVID-19, adapting PMTCT services to reach mothers and infants are crucial. Further adaptations to increase infant testing coverage may be needed, such as catch-up campaigns for infant testing, or SMS or telehealth consults by providers or peer mothers to support postpartum mothers on dosages and appointment scheduling. Countries may also consider community-based DBS sample collection to minimize the need for mothers and infants to attend facilities. With that, this concludes the presentation. I'd like to thank you so much for listening.
Thank you for your presentation, Alexandra. So finally, Isabella Lopez will present the use of a walk-in HIV and STI testing model for at youth age 13 to 24, assessment of the impact of the COVID-19 pandemic on the testing services, and she will doing this for UCSF Marsani College of Medicine.
Hello everyone, my name is Isabella Lopez and I am giving this presentation today on behalf of the Ybor Youth Clinic and the University of South Florida. Our presentation today is on the use of a walk-in HIV and STI testing model for youth ages 13 to 24, assessment of the impact of the COVID-19 pandemic on testing services. The University of South Florida Department of Pediatrics Ybor Youth Clinic serves youth from the ages of 13 to 24. Although it is university affiliated, it is operated as a storefront clinic in a high HIV and STI incidence area of Tampa. The clinic location was chosen to serve the large number of disenfranchised youth who frequent the neighborhoods surrounding it, and was built to serve their needs. Services include HIV and STI testing and treatment, prevention services and counseling, sexual and reproductive health care, referrals to specialized care for physical and emotional trauma, and linkage to other youth programs in the community for other needs. Crucial to the clinic's success is its youth-friendly atmosphere and its ability to offer free walk-in HIV and STI testing. Evidence supports the concept of providing healthcare for youth in an environment tailored to them, while the ability to offer free walk-in testing provides flexibility and convenience. While our staff also does traditional outreach testing in normal times, our easily accessible free walk-in model encourages many youths to come to us at the clinic. This year's COVID-19 pandemic resulted in a switch from our normal walk-in testing to a call-in model with phone screening and assignment of a testing time slot within a day or two of the call. This change in service delivery provided a unique opportunity to evaluate the efficacy of both approaches to testing in our youth population and assess the effects of the pandemic on testing results. In 2017, we began development of a database to collect information to track the demographics of patients served by the YYC, how patients found out about the clinic, the type of service for which they came to the clinic, and services delivered. Over time, we have added information about social determinants of health and clinically relevant information on test results and time to treatment. For the current study, we extracted data from January 1, 2017 through September 31, 2020 to assess the number of walk-in visits by month, the number and type of both STI and HIV tests performed, and positivity rates for these tests. Our objectives were twofold. First, we reviewed trends in walk-in visits over the past 3 years to assess our delivery model and its utility in identifying STI and HIV infections in our target population. Second, we looked at the effect of the COVID-19 pandemic on our ability to continue to deliver services and on the positivity rates for infections in our patients. This graph depicts YYC services from 2017 through 2019. The information from 2017 shows patients' stated reasons for coming to the clinic, whereas in 2018, we began tracking actual services delivered. From 2017 to 2018, youth testing increased 72%, and from 2018 to 2019, another 23%, likely due to increased awareness of YYC services and an expansion of walk-in testing hours to accommodate increased demand. The fact that in 2019, approximately 50% of patients were repeat customers supports our youth-friendly approach. Over 70% of youth report that the YYC is their only place to receive health care, and less than 50% have health insurance confirming the need for our services. Additional data from 2019 showed YYC case-finding rates were 23% for bacterial STIs and 2.9% for syphilis. We also identified 9 out of 52 of the new HIV infections in Hillsborough County youth aged 13 to 24 through our walk-in testing. At the end of March and in April 2020, we modified services in response to COVID-19. Walk-in testing was discontinued and other services were cut back. All patients seeking services were instructed to call the clinic nurse manager. We instituted screening measures for patients coming to clinic, followed university recommendations for cleaning and PPE, minimized patient time in clinic, and switched appointments to telehealth when possible. Notifications were posted on the clinic door, on the clinic website, and on social media regarding these changes. By mid-April, modifications were in place that allowed the accommodation of all youth calling to schedule HIV or STI testing or request appointments. Patients were screened for COVID symptoms/exposures and assigned a time slot for their testing. The numbers designated as walk-in from April to September in the chart on the left reflect youth who called in for testing, while those in January, February, and early March depict traditional walk-in testing. Overall, average monthly clinic visits declined by 34%, from 215 to 135, from May to September compared to the first 2 months of 2020, with testing visits declining by almost 50%. This is a comparison of clinic testing in 2020 for the period before COVID, January and February, to the period from May to September after the clinic had made adjustments to its procedures in response to the pandemic. The numbers reflect averages for those time periods and include testing done at walk-in, designated time slots, and also at scheduled appointments when clinically indicated. Despite our ability to see all youth who scheduled appointments, STI testing decreased an average of 33%, while HIV testing decreased by 13%. The increase in syphilis testing reflects the fact that during this time period, we added a tester with phlebotomy certification, which facilitated more routine syphilis screening. The absolute number of diagnosed gonorrhea and chlamydia infections decreased along with the number of tests performed. This did not occur with the number of diagnosed syphilis cases due to the increased number of tests performed by the new tester. This chart shows case finding rates from May to September of this year compared to the rates in May to September of 2019. There was no statistical difference in rates for any of these infections in this analysis, and rates remained consistent with the diagnosis rates seen traditionally at the clinic. HIV diagnoses at the clinic are much less frequent, but 2 new cases occurred in the first 2 months of the new year, 1 in April and 4 from May through September. These numbers are in line with our historical averages. The walk-in testing model at the YYC is very effective based on the increasing number of tests performed and infections detected in the past 3 years. We demonstrated that increasing open access through walk-in testing increased the number of youth served. The COVID-19 pandemic resulted in a significant decrease in the number of patients for whom we were able to provide services. We increased the number of youth getting tested by switching to scheduled testing and reminder calls for appointments by the end of April. Although we can now accommodate all who call for testing, and most of them are showing up for their appointments, testing numbers remain below previous norms. It is unclear how much social distancing and decreased perceived risk for STIs has contributed to this drop in demand for testing, versus other reasons, such as the inconvenience of scheduled appointments, hesitancy to come to clinic because of the risk of COVID exposure, or diminished immediate importance of HIV and STI testing in the face of constant messaging regarding COVID. Continued monitoring services utilization and measuring behavior change during this pandemic will help us as providers adapt to the changing needs of youth and continue our efforts to prevent, diagnose, and treat STIs and HIV.